Hi, everybody. Welcome again to our fertility interview series. Today, I'm super excited to welcome Dr. Sonal Karia to chat with us. Dr. Karia and I have shared patients for many years. She's a fertility specialist with Janaea, and she's also one of the certified subspecialists in infertility and reproductive endocrinology. So that's that CREI qualification that we've talked about before, and that really is held by less than 80 specialists in Australia and New Zealand. So Dr. Karia seems to consult everywhere, but she's basically in Liverpool and Meadowbank, also doing procedures in the city. So I'm really honoured that you've made time in your crazy busy schedule to chat to us today. So thank you and welcome.
Thank you so much for having me. It's a pleasure to be with you. And how better would we both spend our public holiday, right?
Yeah, exactly. Yeah. By the way, everybody, it's the public holiday. We're pre-recording this. We've had a couple of, false starts on this interview. So I'm really excited that we've managed to pull our schedules together. Okay, so people have submitted questions like they do every month. So we'll just jump straight into it. But what I wanted to ask you first is, what would you say some of the kind of myths or theories that people have about their fertility issues that you might need to help clarify for them when they come and see you?
So Belinda, it is actually quite surprising that in 2022, we're actually talking about this question. In fact, I was asked to give a presentation. And when you have to do a presentation, you have to find evidence. You just can't say what you feel like or what you think is true. But there are very common myths that go around in the community, both in terms of the fertility and the nature of the actual process. So in terms of fertility, one of the biggest things that I think we need to bring out is the impact of advancing female age. And unfortunately, I think even in this day and age, there are women who have this misconception that if I don't get pregnant, then IVF is always going to be there. Now, I really need women to know that even in IVF, I am using their eggs, or at least the aim is to use their own eggs. And as women, we are all born with a fixed number of eggs. We are born with all the eggs that we are ever going to have. The more important thing is that not only the number keeps declining because we keep using them, but the quality declines after a certain age. And that's why you will notice, after about 36, 37, it's harder to get pregnant. But even if you do, then it's more likelihood of miscarriages, abnormalities in the babies, difficult pregnancies. So what our grandmothers and old midwives tell us, try and plan your pregnancies when you're younger, is actually true. And they were very good at observing that, although they didn't understand the science. Now, a bigger misconception is actually that male age doesn't matter because they can make new sperm all the time. And I think that is something that we really need to throw out of the window, because male age does matter. If we think of what aging is, it's practically speaking damage to our DNA, right? And DNA is the component that the sperm is passing on to the egg to make a baby. So that's almost like the blueprint from the man to make the baby. And that DNA cures a lot of damage over a period of time, especially if the man is over a certain age and then getting some exposures through their lifestyle, so things like smoking and chemotherapy and being too much overweight and that sort of stuff. And that concept that, okay, their age doesn't matter because they can keep making fresh new sperm has completely gone now. The other thing we need to remember is that when men father a baby after a certain age, probably about 45 to 50, that's when the chance of certain genetic conditions starts increasing in the offspring. So that's another thing to keep in mind. With the process itself, also people have a lot of misconceptions. And I frequently get questions as to, doctor, do you think, it's okay for us to wash ourselves after intercourse, or should I lie down and put pillows under my bottom? Is there a specific position for intercourse? And I often tell them that all that doesn't matter at all, because it's a bad example, but it does put things into perspective. We have to think that sometimes, unfortunately, women do get sexually assaulted, and even with that one act of intercourse, obviously they're not thinking of their ovulation, they're not thinking of the position, they're not thinking, in fact, they're resisting that activity, right? And they still find themselves pregnant. So if all that was really important, like hanging yourself upside down after intercourse, then that wouldn't have happened.
Yeah.
So
And
these,
that's an interesting, sort of, I mean, obviously it's a terrible thing to happen, but I often sort of, when people say to me, oh, I've been really stressed, that's probably what's going on. I think it was stress that impacted my cycle, and I often use that same sort of, unfortunately, there's a lot of women around the world who are, not that you want to, compare stress levels, but who are extremely stressed and fall pregnant in war zones and in those situations like you're talking about. So obviously stress doesn't help, but I think women sort of put off their cycles or blame themselves because they're under stress. And obviously, if something's really acute, you don't need to be doing an IVF cycle at the same time. But if it's kind of like your job and your lifestyle, obviously taking some measures to try to manage the stress better. But would you say that's, do you find that as well? What do you find the impact of stress is?
Absolutely. Every single couple or person who walks through the door says, oh, my job is very stressful. And the only thing I have to say is just look around you and try and find me one person whose job is not stressful in a country like Australia or in a city like Sydney right now. The usual stressors, like you said, of life do not matter. It's an acute stressful event like a death in the family, or say this building catches fire and I lose all my business. Something like that would affect it. And women need to remember that the only two ways in which stress can have a very big impact is, one is their ovulation.
Yes.
When they go through an acutely stressful event, their brain will obviously receive a message that this is not the best time for reproduction. And the first thing the brain tries to do is shut off ovulation. And the second thing it will do is it will put them off intercourse. If these two things are not happening, that means their body is coping with the stress that they are experiencing at that time. That in that case, that fertility is not going to be affected.
Yeah.
So that is another myth that I think, yes, we need to get out of the window, because stress is highly, highly overrated in the fertility world.
Yeah. So it's interesting what you said about, obviously, we know a lot about the advancing female age, and I think a lot of women become acutely aware of that. Unfortunately, not until they start to try. Pretty much every woman that walks in here says, I wish somebody had have told me earlier that, it was going to get harder. But I think one of the difficult things is that men often don't see that importance even when the female does. So we need this almost re-education of men of no, we don't have lots of time. We need to sort of be potentially trying earlier if you're in that position. But what you said about the sperm was really interesting, because one of my questions to you was actually going to be, does a good semen analysis mean that male factor isn't an issue and it's all up to egg quality implantation? Because I hear that a lot in my clinic, and I'm always like, no, the men need to be healthy and involved, but they get this one test and go, it's fine, so motility, morphology, concentration counter fine. Would you say that even when they're fine, the health of the sperm, the age of the sperm does still make an impact?
Absolutely. I don't think there is any doubt from the literature that it does have an impact, because like I said, it's the quality of the DNA. And we also need to remember that there is so much that is unknown about the sperm. Okay, we know very little about the sperm as far as I'm concerned. Overall, yes, a semen analysis is a reasonable test, but we also have to remember that there is a lot of variability. So if a man gives 12 samples in 12 months in a year, they're all going to be different.
Yes.
Plus, obviously, age-wise, like I said, certain autosomal dominant genetic conditions start then becoming predominant. We have already noticed that men who are above a certain age will father children with a higher risk of autism spectrum disorders, ADHD. That data is already widely available. So I don't think that men can be excused by saying that, okay, my semen analysis is normal, so now it's not my problem.
Yeah.
It's a problem. And yes, I think, more than 80 to 90% of the contribution does come from the egg, because we have to remember that the egg is the largest cell in the body, in the human body. The female is the largest cell, and there is a reason for that, because the egg has got so many factors in it which can actually correct the damage that the sperm has.
Yeah.
But the sperm can never compensate for bad egg quality. And that's where the crux of the story lies. So if you look at any website of any IVF unit and look at the success rates, one factor that will always be there will be the woman's age, and then the other factor will be success rate. Nobody actually puts success rates according to the male age, but we have now started gaining a lot of understanding that the thought process that we had 30 years back, that if the man's semen analysis is fine, then he's probably not going to be contributing to the problem. That's not true.
That, and it's interesting that you say 30 years ago, because I have, you know, every second patient walking in here saying, oh, look, it's just me, it's all me, he's fine, kind of thing. And, you know, I'm always like, you're in this together. And even if, I guess, you know, egg quality, like you said, the egg can improve the sperm, obviously, if the egg is young and healthy, you know, but if the egg isn't young, you know, I always say, like, make the semen quality as good as possible, really working on, you know, your oxidative stress levels, diet, lifestyle, everything, because it gives the egg less work to do, right?
Correct. And beyond a certain point, the egg will start losing that capacity, right?
Yeah.
We cannot just expect the egg to keep doing that all the time. And like you said, again, age then becomes the main factor, and the age of the woman. That's the age of her eggs. So a younger woman will compensate much better for poor sperm. An older woman will find it difficult. And again, it brings us to the same point, that try and plan your pregnancies younger if you can.
Yes, yeah. And would you say that you see couples that you think, when they're still trying naturally, are not trying enough? You know, I certainly see a lot of people, unfortunately, when they've been trying for a while, that they might be really pinpointing ovulation using pea sticks or whatever they're doing, and they have a couple of attempts a month, you know. And I'm always like, you've got to try, there's got to be, obviously you only conceive from one of those attempts, but what would you say the kind of optimal, while you're still trying naturally in that fertile window, is for kind of frequency?
So I don't think that there is a fixed frequency, and this is a very common question that people ask. Doctor, should it be daily? Should it be second daily? Should it be morning? Should it be evening? And again, I keep telling them that that really doesn't matter, because the fertile period is an actual window. It's not a day.
Yes.
And if you look at all the research, it is actually the 2 to 3 days leading to ovulation. Those are the most important days. It's not the exact day of ovulation. Plus, of course, you know, it's not really always possible to get the exact day of ovulation just by monitoring it at home. And then monitoring it through blood tests and ultrasounds is quite invasive and tedious. So I keep telling my women that, you know, if you did a survey of 100 women walking on the road who got pregnant tonight, and then you ask them a question about ovulation, I'm pretty sure about 40-50% will not have any idea of what ovulation.
Probably more, yeah.
Or, you know, what was their ovulation period. They just live a normal life, have intercourse once every 2-3 days, miss a period, and then one day, you know, rocking on a chair, think, oh, I've not got a period for a while, let me check. That's how they find themselves pregnant. So that story is a bit frustrating to women, because they think, oh, if it's happening so easily for them, why am I sitting in your office and talking to you about this?
Yes.
Keep telling them that, okay, as long as you understand the concept of ovulation and the fertile window. So if your cycle is very regular, you actually don't need anything fancy, right? You know that your ovulation is going to be 12 to 14 days before your next period. And I tell you to calculate from the next period, because it's the second half of the cycle that's a little bit more fixed in duration. The first half is quite variable. You have to think of their next period minus 2 weeks and start trying 2 to 3 days before that. And then try for a period of 5 to 7 days, because sometimes ovulation is a bit early, sometimes a bit late. So you're covering the whole fertile period.
Yes.
The other problem with this whole concept of fertile period is, often in the first 10 days or so, when they know that they are not fertile, they won't have intercourse, thinking that, oh, the sperm count is going to go down. I want all that sperm to be there at the time of my ovulation. Now, obviously, if the man ejaculates, the sperm count will go down, but they don't think what they're doing to the quality, because all the damage that sperm occurs in terms of the damage to its DNA and its quality is in that passage. It's not actually in the testis. There is a reason that testis is the only organ in the body that hangs outside the body. And it's because sperm doesn't like core body temperature and the exposures through environment and through a diet and lifestyle that it gets, and that's causing the DNA damage. So I have to explain to them that please do not avoid ejaculation in those first 8 to 10 days, because what's happening is, for 10 days, it's cooking up in that passage, getting all that damage. And then right at the time of ovulation, he's giving you all that damaged sperm. You would rather have fresh sperm coming from the testis all the time. So it's actually good for men to ejaculate once every 2-3 days.
Yeah, yeah.
That concept again becomes very important as far as ovulation timing is concerned.
Yeah, absolutely. And that's one of the best ways to kind of improve DNA damage in sperm when it's been tested too, right? It's just regular ejaculation, you know,
Correct.
like free, easy-ish, hopefully. Yeah. And so would you say that in your clinic, you see the impact of people when they change their diet and lifestyle on egg and sperm quality?
Yes, I think it should definitely have an impact. And there is so much research. In fact, often people ask me, doctor, what is the best diet that I can have? And there's some data that the Mediterranean diet seems to be the best fertility diet. And I'm sure you probably know a lot more about that than I do in your practice. And I can see why, because obviously the Mediterranean diet, they tend to use a lot of fresh vegetables and salads and olives, and they cook in olive oil. So they are actually getting a lot of antioxidants in diet already. So if we go to a Greek restaurant, almost certainly a Greek salad comes out on the table and you fill up a quarter of your tummy with that.
Yes.
So you eat lesser of the other junk stuff and you're eating a bit more of the healthy stuff, which is actually helping you. Yes, probiotics play a role, but I think prebiotics play a bigger role, because the prebiotics is what we see on a regular basis on TV, the 5 serves of fruits and veggies. And we often think, oh, this is all rubbish, nobody can do it. But actually speaking, it's true. It's good for your body, because that's the antioxidant stuff that you're going to get in your diet. So when a man comes with a high sperm DNA fragmentation on a result, or in general, if I find lifestyle issues, and almost always we have to spend 10-15 minutes in a consultation talking about lifestyle, that's when I add all this into the mix. I tell them, everything that ends in a berry is actually antioxidant. So you put some strawberries or blueberries or cranberries or whatever you can in your cereal and gulp it down. You've actually taken a good dose of antioxidants. All the greens in your salad, everything that looks green is antioxidant. So simple stuff like that actually goes down people's throat quite well. If we tell them to do something too complicated, then they can't maintain it for a long time.
Yeah. And what would you say is the biggest, like the intervention, the lifestyle intervention that you feel like has the biggest difference? Is it alcohol or smoking or diet or supplements, or, is there something that you see or not really?
I'm sure you know the answer to that. And I'm sure every single person you've spoken to has said that unfortunately smoking does have the highest impact.
Yeah.
I do believe from my reading that it has more impact than chemotherapy.
Yeah, right.
That's how bad it is, because we have to remember that cigarette is not only nicotine. It is probably about 3,000 other chemicals. And we can only imagine what they do to our DNA. So if somebody stops smoking, okay, they've automatically probably improved their chance of a successful treatment by about 30 to 40%.
Wow.
Now I can run an IVF cycle in a standard fashion. If that IVF cycle doesn't work, I can try and make some small changes based on what I saw in the first cycle. I can try and make it 10% better, right?
Yeah.
Nothing I can do to make something suddenly 30 to 40% better. But if you stop smoking, suddenly you have improved your chance. So we tell people, you'll need double the number of IVF cycles if you continue to smoke compared to other age-matched women or couples who don't smoke. That's the honest fact.
And even how many cigarettes, I mean, obviously, none is good, but, would you say even going down to like 1 or 2 a day? Or the reason I ask this is I have so many patients who don't tell their IVF specialist about their smoking. And I'm like, you need to be honest, right? Like they're not there to judge you. They don't care. Of course they care, but they care to get you the outcome. And many will say, I've given up, or, they say, I'm just doing a couple a day now. I'm like, still makes a difference, right?
It does make a lot of difference. And in fact, the data is unfortunately the same for passive smoking. And can I just add one more thing here? And I'm not trying to scare people by listening to this, but the honest fact is now we have a lot of data that if one of the parents is a smoker around the time of conception, the chance of childhood cancers in the child increases. Now, that's the stab in my heart that I wouldn't like, because if my smoking habit increases my child's risk of getting cancer in childhood, probably that's enough for me to say, okay, this is not a good thing. It's not good for me. It's not good for my pregnancy. It's not good for my baby.
Yeah. And that's either partner just being exposed.
Yes, that's right. And the effect is the same. Passive smoking doesn't have any different effect compared to active smoking. So I would say, stop. That's the one thing that even in moderation is not good.
Yeah.
Because the same question comes up about alcohol, right?
Yes.
And I keep telling people, a glass of wine with dinner is really not a problem. You can continue to have a little bit of alcohol. And of course, once you have a positive pregnancy test, we say don't have it, only because I don't think that, it will ever be an ethical research project to find out what is a safe dose in
Yes.
pregnancy.
Yeah,
I'm
yeah.
sure there is a safe dose. I'm sure women sometimes gulp down a little bit of alcohol, at social events, even while they're pregnant. But we will never be able to know what that safe dose is because it's just
Yes.
not an ethical research project that any
Exactly.
committee will approve. But
And it's probably different in everybody anyway, depending on their detoxification pathways and all sorts of things. So I mean, yeah, better not to.
better not to. Exactly, that's right. So as far as our lifestyle and exposures are concerned, these two are the big factors. And we are actually a country of people who love, their beer and barbecue. And
Yeah.
so sometimes, you find people, they start drinking on a Friday afternoon at lunch, and then they've been drinking till midnight. And the binge drinking really doesn't help. But a glass of wine with dinner, I don't think any of us would talk about it. Yeah.
And there's possibly not enough studies on it yet because it's all a bit new. But what do you feel like about vaping? I mean, I always say like, no. I mean, I think in one way, obviously, you don't get all the other chemicals, but the amount of nicotine people get because it's so easy to vape inside or, in other environments, I feel like they do it more. Would you say that's just as bad?
So I couldn't agree more. I don't think that vaping is kind of a lesser culprit. Okay?
Yeah.
And the primary reason for that is we don't know the impact. And I don't think we will ever know the full impact because, again, how do you conduct a research like that?
Yeah.
That's the problem, right? You can't say, okay, I'm going to expose 100 people to vaping and I'm going to expose 100 people to not that stuff and then try and compare. That's unethical. You cannot.
Yeah.
So
See who has the healthier baby, see whose cycle works. That's what I say to people, all of this stuff is so hard to get research on, even use of supplementations, ubiquinol and things, there is research on that, but it's hard to recruit into those studies because as soon as somebody says, oh, that sounds good, I'll take that for equality, and they say, well, you might be in the placebo group, they're like, I'm out, I'm just going to go and buy that anyway if there's no harm. So it is really hard to get
these. The problem is, how do we know that there is no harm, right? Even for that, research has to be done because we know that everything comes with a good effect, but then there are lots of things that comes with side effects as well. And when people think something is natural or something is a supplement, they think it's actually good for my body.
Yeah.
Now, a prime example would be fish oil. Fish oil is good. It's omega-3. It's fantastic for your body. But I have to remind women that if you are on fish oil and if I'm doing an IVF cycle for you, you need to remember it's a blood thinner.
Yeah.
It may increase the risk of bleeding with the procedure. So at least a few days before the procedure, I really need you to get rid of it.
Yeah.
That is the sort of stuff that sometimes doesn't come out in history because people think that's only a supplement. I don't tell the doctor. You need to tell the doctor every single thing that you're on.
And especially, I mean, to everybody, but especially if you're not working with somebody, because obviously when you're seeing somebody like me, we've got like, when to start, when to stop, everything around your cycle to kind of take into that. But even on that same note, the quality of the fish oil, some are really actually oxidized and probably pro-inflammatory, and other ones, are actually giving you the omega-3s, and they've been, third-party tested at various points in their, lifespan of the supplement and things like that. So, I say this to people all the time, like it's not only the quality, like the quantity and the dose, and if you're taking it, but the quality, and are you getting what you're getting? Are you stopping at the right time around your medications and procedures and transfers as well? We tend to kind of stop things around transfers, so there is so much kind of in that as well.
Yeah, but see, the other thing also from that perspective is the herbs, the natural herbs that people talk about. And I have to keep a very straight face and tell my patients that I'm really sorry. Even if you get me the names of the herbs, I'm not herbal medicine. I will not be able to advise you. So your herbal medicine specialist will have to be as honest as I am and tell you what it's doing to your body.
Yes.
Surprisingly, I've had 2 incidents which have really, really scared me. One, when somebody said I'm on Chinese herbs, and then I did go into a little bit of detail. She pulled out a packet from her bag and she showed it to me, and it said zooclomifene. And I'm sure clomifene is ovulation induction agent, which we use practically for a lot of women. And I was actually going to put her on clomifene, and she was already on that stuff.
Oh.
And she thought she was on natural herbs. And my second more scary experience has been somebody who thought they were on Ayurvedic herbs from India. And then her blood levels of certain things were so out of whack that I got a call from the lab on a Saturday morning. And I had to call her and tell her, I want you to be down into the Westmead Hospital emergency right now, because I can see that you're going to throw a embolus. She was actually at a risk of venous thromboembolism. She could have died out of it. They actually kept her in the hospital for a few days trying to reverse the effect of all those drugs and kept her on blood thinners and stuff. And then they released her. And ultimately we realized it was the Chinese herbs that was causing all those alterations in her, in her clotting.
Oh, look, I'm the same. I make everyone off their herbs from other practitioners. I'm like, guys, just be off them. Like herbs are different to nutritionals, you know, like vitamin C, you know, fish oils, things like that. Obviously still need to be looked at and when to take them and what they interact with. But herbs, yeah, I'm like, no herbs around your cycles, even if people say, oh, but they're for implantation or whatever. I'm like, do you know what? Just don't, you know, well, I'm like, you know, I'm writing down in my notes that I've told you or I've recommended for you not to, you know, so I think people really appreciate that information as well, because it is really important. And that's why I love doing these sort of things, because, you know, we all learn from each other, but it's really important. You know, I think that most people a lot of people are seeing, whether it's a naturopath, a nutritionist, an acupuncturist, whoever they're seeing, you know, so the more that we can actually be really transparent. And I say to people all the time, you know, the person doing your cycle is the boss at that time. If they want you off everything, even though there's things that I believe from my research you can be on, I'm like, they're in charge at that point. And so what we've done to prepare you in the build up doesn't just drop away in that couple of weeks of your stim cycle or whatever. So if they prefer you off everything, you're off everything. You know, if they just say fish oils, fine, fish oils. But, you know, I think that level of respect is really important.
So I think, you know, yeah, that might sound quite dominating, you know, sometimes to some people, that how can you say that my other specialist is not giving me the right advice? But what I tend to also sometimes do is, if I see that, you know, they're really keen, or if I see that they are feeling very hesitant to stop stuff just because I don't understand that stuff and I can't give them advice, I tell them either to talk to Mother Safe, which is a great organization which gives so much information about exposures in pregnancy. And if they don't have the information, of course, they'll honestly tell you. Or I can liaise with their specialist and try and get some understanding. So if they're seeing you and you're recommending something, of course, I can pick up the phone and talk with you, and I can get an understanding of, okay, Belinda, why are you recommending this? How is it going to help her? And is there any side effect that I should worry about in the context of my treatment cycle? If you're able to reassure me and give me the information, then I might be, okay, you know, it's fine, you can continue, because somebody is overseeing it. Somebody who has the knowledge and has the understanding of that product is guiding you, and that I don't mind. But I think when it comes down to us liaising with each other and like a multidisciplinary approach, rather than being so dominating that, no, either you listen to me or it's my way or the highway, it doesn't work in 2022, right?
No, exactly, which I think is amazing. But I also don't think it's particularly dominating for whoever the specialist is, whilst you're just on that, you know, 10, 14 day of stims around, you know, like, it's sort of like I always say to people, like, they're responsible for you in that time. And, you know, if they are hesitant, like, I can understand that as well. So, you know, most of the time, you know, I think, you know, we all work a lot together and we kind of understand who knows what they're doing and whatever. But I mean, I think it's really important that they know the outcome that they're going to get is the outcome that you think that, you know, that they're wanting. Because like you said, you know, you are a miracle worker in many ways, but you can only work with the ingredients that you've got. You know, like, they're bringing the sperm, they're bringing the egg there. And like you said, you know, even different cycles, you might get 10% improvement, sometimes more, sometimes less. But, you know, you want to be able to know what your variables are, because, you know, you can't improve. That's what I said to people, you know, you can't improve the quality really. You know, maybe things like DHEA or Testosterone or whatever can maybe make slight improvements, but nothing's a known game changer, is it?
So I keep telling people that, you know, it's always easy to make your egg quality bad. Start smoking and they'll go down the drain. That is very, very difficult to make them better, because you were obviously born with them and you've been having all these exposures for a lifetime. It's like, you know, yesterday that egg started getting exposed to what you were doing. They have been sitting there in your ovaries since the time you were born. To reverse that impact is going to be quite challenging. So there is some reasonable data for things like coenzyme Q10, maybe a little bit of data for melatonin and that sort of stuff. But I think we need to still learn a lot more about those supplements and products and then start recommending them. So one of the things that I do is I have a lot of discussion about the so-called adjuvants in IVF.
Yes.
But I also clearly tell people and document that the uncertainty in the literature and the research that we have is very widely known. And probably, you know, that will remain for a period of time till we get some really robust data.
Yeah, absolutely. So tell me, one of the other questions that we often get is, you know, why do you feel like AMH can be low for age? So, you know, obviously as we get older, our AMH levels decrease, and that's kind of natural. But if you saw a 33-year-old with lower levels, for example, you know, would you be suspecting endometriosis if she doesn't have history of premature ovarian failure in the family? Or what are your sort of thoughts around?
Oh, that is a presentation and topic in itself. And I think we could have a whole day's workshop on that, to be honest with you. But in short, there are so many factors, right? So you have a stock of eggs at birth, and I'm sure that everybody is born with their own stock of eggs. No two people have the same stock of eggs at birth, and that is highly, highly influenced by our genetics, but also by other things that might happen during our lifetime. So there is a good concordance in the menopause age between mothers and daughters, and we've known that for a long time. So family history does become very important. There are genetic factors, and the prime example of that would be something like Fragile X gene mutation, which is a very specific gene change that can reduce your egg reserve.
Yeah.
And can push you into premature ovarian insufficiency. I don't like calling it menopause because it's a very absolute term, and we know that women do conceive after going through that phase as well. So a milder term is insufficiency that we now use. Equally, like you mentioned, things like endometriosis are known to be associated with low egg reserve. And a lot of the autoimmune conditions that we test for in women who have low egg reserve are actually associated with low ovarian reserve. Plus things like, you know, exposure to chemotherapy, or God forbid, if they've had a big ovarian cyst and we've done a big surgery, part of those eggs have gone away with the surgery. Sometimes an ovary might be lost because of that. So surgical menopause and surgical premature ovarian insufficiency is quite well known. So there are so many factors that I have to start thinking about. Generally speaking, if say the AMH is less than the 5th centile for that age group, I would run what is called as a premature ovarian insufficiency screen, which is a series of blood tests and, like, you know, ultrasounds, and sometimes a little bit more evaluation if I prove that that woman is in that situation. Because I not only want to look after her fertility, but also after her health. And like I said, that's another conversation for another day, because menopause has so many bad effects on a woman's health. So do that evaluation, look after her health as well as her fertility, and then take it from there. And then things like endometriosis specifically that you asked for, partly will depend on the family history again, partly will depend on her symptoms. Does she have symptoms of endometriosis? And fortunately now in today's day and age, we do have specialists who are now trying to do more specialized ultrasound scans and MRIs to look for those pathologies. Because like you probably know, the gold standard for diagnosis still remains surgery. And women are obviously not jumping with joy to have surgery, neither are specialists jumping with joy to do it if it is not necessary and avoid those risks and complications. So it's a whole sort of evaluation in itself.
Yeah.
Start talking about what to do for the fertility and what to do for her health.
And it's interesting you mentioned about, you know, sort of autoimmune and things. I often say to people, because whenever anybody says like, oh, you know, when I was young, like, you know, it's told we were going to get pregnant so easily, and, you know, now it's so hard, you know, and like at the time when you learned that, it was true, right? I think the problem is that we didn't get another class at 26 or something that said, oh, by the way, you know, at some point now it's going to get a little bit harder. I mean, maybe not at 26, but, you know, to kind of know for the future. Would you say for women, if they know they maybe have history of endometriosis or suspected endometriosis, they have some sort of autoimmune disease, and obviously if it's an option for them to be either trying to start their family earlier, or even considering if they're single and maybe early 30s, you know, egg freezing, knowing that those conditions really can impact egg quality, you know, and then potentially implantation, but, you know, worry about that part later?
Well, you're trying to cover things that I could have a workshop for a whole day on another topic.
Yeah.
But
well, we do it all in an hour.
Yeah, that's true. And I I couldn't agree more. So yes, if there are already factors in history or in the family history, then I think it would be a reasonable option for women to have some counseling, even before they even think of having a family. Why not? They just need to know the hard facts and then they can plan accordingly. And as far as things like endometriosis and egg freezing and all that is concerned, now, egg freezing is a very complicated topic, and it's always a difficult consultation, I would say, only because when we start talking of egg freezing, people think that, okay, now I've frozen my eggs, I can have a baby at 50. And that misconception is what kills me, because I have to keep reminding them it is a backup option. It is not a guarantee. When we thaw those eggs, try and put it with the sperm, we don't know even whether fertilization will happen or it will not. So it might stop at that point. And even if there is fertilization, what quality of embryos will you make at that time? We have no idea. So if you use your eggs at 32 and then come back at 45 to use them, at 45, your fresh eggs are no good, right? And then your frozen eggs, if they don't thaw out well or they don't work, you're a little bit stuck, because then your only option is to go and get an egg donor. So as a backup option, I think it's reasonable, but I always tell women that if it is not a disaster for you to get pregnant now, that you're 32, 33, or whatever age you're seeing me, if you have a partner and you know that this is the person that I want to have babies with, then my honest opinion, both as a, somebody who is older to you and also as a medical professional, would be try a pregnancy, because that's your best way of proving that you are fertile. And yes, your pregnancy will be easier. Your chance of having a healthier baby will be better because you're doing it younger. So that discussion is very clear. The other thing that women often wonder is, what's the best time to freeze eggs? Is there a good or bad age? And I don't think there's a straightforward answer, because if a 25-year-old comes to me and says, I want to freeze eggs, I'm worried. And if she doesn't really have low egg reserve or any other factor that should make her consider that at that age, then I might discourage that, only because her chance of requiring those eggs, her chance of actually coming back to use them is very low.
Yeah.
She's a young, fit, healthy person. She's very likely to find the Mr. Right, have sex, have a baby, right?
Yes.
So then I would think, okay, are we doing an invasive procedure and putting her through that risk with very low probability of benefit out of that procedure? Now, equally, if a 40-year-old comes to me and says, freeze my eggs, I actually keep a very straight face and I tell them, I don't know if I'm freezing your fertility or am I freezing your infertility.
Yeah.
Because I'm freezing very poor quality eggs. You might feel like a 30-year-old, but your ovary always knows your age.
Yes.
Your eggs are always the age that is equal to your chronological age. So personally, I do think that the sweet spot seems to be somewhere between the early to the mid 30s. If you want to do it, that's probably the right age to do it, but I don't think we will ever have a completely straightforward answer to that.
No. And the amount that you need, people don't realize, for the chance of a successful pregnancy is like a lot more than, I guess, what is it like, you need 20 eggs at 35 to assume that you might get a baby or something. It's not.
So looking at the current literature and evidence for younger eggs, if you freeze them in a good laboratory and use good technology, then if you have somewhere probably around 8 to 10 good quality mature eggs frozen, we could hope for one baby out of it at least. And I'm saying hope for, I'm not saying guarantee again.
And what age would that be? Like under 35?
Yeah. Yeah. But obviously, the older you are, even if you have mature eggs frozen, a lot of those eggs are themselves going to be abnormal. And that's why the risk of abnormality then in the offspring starts increasing. So then you need a larger number to be frozen. Now, the hard fact is, as you get older,
you don't
the
have
chance
that
of getting eggs and in a particular cycle reduces. So then it means you're going through a lot of IVF cycles just to freeze that so-called adequate number in one. And the biggest thing to put into the equation is, what is the size of the family that you've always imagined? If you have in your mind that, okay, I would be happy with one baby or two children, that's very different if somebody culturally or otherwise thinks, I want to have a really big family, I want half a dozen children running around, then that number is obviously going to be different for that person.
Yes.
So all this needs to come into the equation. And this is something that we all discuss with patients. These conversations, like I said, are not as simple as they appear from far. They're actually quite difficult, because a woman's trying to, in one way, make decisions for her future and predict the future, which is very, very important.
And it is difficult because, like you said, you're not even getting halfway, right? You're just getting to that kind of egg collection, not seeing fertilization, embryo progression, chromosomal viability, implantation. Everything is tricky. And I think, too, would you say women who are a little bit kind of polycystic or potentially even just multifollicular, those sort of older women that just have buckets of eggs, and when you're doing a full IVF cycle, there's massive drop-offs, and they might get 10 eggs collected at 40 something, but maybe one embryo on day 5. Would you say that those women who are freezing eggs at 38, 39 and get 15 plus eggs, would you say that there's probably not still as good quality based on age, even though they feel like they've got the numbers?
In fact, I think the opposite is true, because unfortunately, the hormonal profile in women with polycystic ovaries is highly altered. So even in a younger woman, when you run an IVF cycle in a woman who has polycystic ovarian syndrome, those are some of the most difficult cycles to run, because you will have a bucket load of tiny follicles sitting there. Now, all those tiny follicles will obviously produce hormones. So their estrogen levels tend to go very high in their cycles. And one of the main risks that we are worried about, especially in the polycystic group, is what we call as the overstimulation or ovarian hyperstimulation.
Yes.
So we have to keep our hands so controlled. The other problem in them is they have a very narrow therapeutic range. So the injections that we use for IVF, their window of response to the dose is very, very narrow. You go one click down and they won't respond, and you go one click up and they over respond. And that's another big challenge in polycystic. So often you will be in a situation where you will have 40, 50 follicles. You probably get 5 mature eggs out of them, but you still run the risk of overstimulation, because all those 40 follicles want to produce a lot and make the woman sick. I think it's a nightmare sometimes to stimulate polycystic compared to a woman who is average or under average egg response, because that's the woman that I'm less likely to overstimulate. And even if she gets only 5 or 6 good follicles, maybe I'll get the same number of mature eggs from her.
Yes.
Not put her at any risk. So that's the honest fact with polycystic.
Less of that kind of drop off.
It can. And coming back to the numbers, it's a crystal ball. Younger women, when they struggle a lot, we have to remember that that is the bigger struggle than older women struggling. A 45-year-old having IVF is supposed to struggle. I'm supposed to get bad eggs. I'm supposed to have very low success rates. I can keep my straight face and say, sorry, it's age related.
Yes.
But when a 30-year-old is really, really struggling and having 4 or 5 cycles of IVF, I have to scratch my head much harder, because that's the person I was never expecting. That was my dream patient who walked into my room.
Yes.
It's going to happen very quickly, and it didn't happen. That's the person that is always going to be a much bigger struggle. And it's hard to explain that, but then it comes down to inherent egg quality. I've had somebody who I collected 19 good quality eggs. I didn't have an embryo to transfer in that cycle. And that was a real eye opener for her, that, okay, what the doctor is saying is true. It's related to my quality.
Yes.
With my numbers of fertilization.
Not the quantity. Yeah.
That's how it is.
Yeah, which is hard. They're all hard, but the whole journey is hard, isn't it? Another 5-day question wrapped up in 5 minutes. What would you say about adenomyosis? So, women, I've got quite a few women at the moment whose specialists say, keep trying naturally. Adenomyosis won't affect natural fertility and implantation. Would you agree with that? No,
I would agree with that at all. So first of all,
I've got 2 at the moment. I'm like, I think you need to ask somebody else, because
No, so first of all, I think for people to just have an idea of what we are talking about, because obviously there will be some people who don't know what adenomyosis is.
Yeah, I hope that you all don't know. I always say to my patients, I'm sorry that you know all these words: blastocysts, adenomyosis, follicles, I mean, they're not meant to know these, right? But unfortunately, most of the people watching probably do. But yeah, please talk about adeno.
So I would say adenomyosis is like a poor cousin of endometriosis. Okay. And to explain that a bit better, all women know that there is a lining inside the uterus. That lining, it grows every month. And if we are not pregnant, we shed off all that lining with our period. Then the next month, there's a fresh new lining which has to grow, right? Now that lining, in an ideal world, should grow only inside the uterus. If it starts growing anywhere outside the uterus in our body, it's called endometriosis. And it can be anywhere in the tummy. So it can be on the bowel, the bladder, ovary, tube, wherever, on the lining of the tummy, wherever. Okay. I don't know that people know that endometriosis has been reported in lungs. It has been reported in other organs. It has even been reported in men. Okay. So it is a nasty condition. And adenomyosis is when it actually grows in the muscle of the uterus. So it's not outside of the uterus, but if the lining starts penetrating the muscle wall of the uterus and starts worrying the muscle wall, that's when it's called adenomyosis. Now, I can't agree that it's not going to affect fertility because of the fact that if we logically think of it, it's going to increase the bulk of the muscle. It's going to cause inflammation there because we very well know that endometriosis is a very inflammatory process. It's actually going to alter the blood supply of the lining of the uterus. It's actually going to alter all the factors, the growth factors and things that we need for implantation to successfully happen. So the lining in a person with endometriosis or adenomyosis is genetically very different from a normal endometrial lining. That itself affects it. And we've known for a very long time that these women tend to sometimes have what is called as progesterone resistance. Their body resists progesterone, which is the main hormone that's going to support a pregnancy. So their blood levels of progesterone might be fine. But if the tissues are resisting the effect, then again, implantation is going to get affected. If implantation is affected, placentation is affected, and placenta is going to be the lifeline of the baby. So if you have a poor quality placenta, your entire pregnancy is then going to be affected. And that then takes us to this whole concept that's now going on of, what we call as developmental origins of health and disease.
Yes.
If intrauterine life is bad or is not well nourished, or if you're growth restricted, that can impact your entire life, and not only your life, but now we have evidence for up to 3 generations. So that's the generational effect that we are talking about. So everything has an impact. I don't think we can say that, this is not going to impact. Bringing us back to the same thing, age, because adenomyosis is more common in the early 40s.
Yes.
But if you plan your pregnancies younger, you're going to be at an advantage that you're less likely to have that problem, less likely to have the effect on your pregnancy then.
And would you say it's worth doing some, like whether it's progestin treatment, like a Mirena or some Zoladex to kind of pull the estrogen out for a bit to kind of try to get the adenomyosis under control? Obviously with endometriosis, hopefully it can be removed surgically, even though that's probably not fun. Whereas adenomyosis, like you said, is in the muscle, therefore can't really be reduced and removed surgically. Do you think it's worth having some sort of treatment to kind of settle it all down prior to either IVF or trying again naturally?
So there is reasonable evidence that if people are struggling with their fertility because of endometriosis or adenomyosis, then trying to treat either medically or surgically is beneficial. And I wouldn't say that adenomyosis cannot be treated surgically at all, because sometimes they have one area of adenomyosis in the muscle, which is called as an adenomyoma. So it almost looks just like a uterine fibroid, and you could go and remove it. Or we could also do what is called a cytoreduction. So try and open up the muscle and remove as much of the diseased tissue that we can make out, and then try and suture the muscle back together. A very morbid surgery, I admit, and not often done. So adenomyosis is often treated medically, like you said, not usually with a Mirena, because that will completely stop the woman, and it will take probably a year or more to have some. But things like Zoladex, yes, you can do it for 3 months and then get on to a treatment cycle, or you can start trying naturally as soon as you start ovulating, because Zoladex is something that would put you through a temporary phase of menopause, as if your whole system has just completely shut down temporarily. So there's no hormonal influence on those areas which have the disease. And then the disease can't progress. It actually quietens down the disease and the inflammation. And then you start trying in a much better environment.
Yeah. No, I thought that was the case. So thank you, because there's lots of different opinions out there, which is, very difficult, I guess. Yeah. So look, we're about to run out of time, and I do want to pop it up on Instagram, which cuts us off after an hour. So we'll wrap it up there. But thank you so much for your time. Your knowledge is incredible. All of my patients that I share with you always say you're empathetic, you're kind, you're professional, you know, and obviously amazing at what you do. But, you know, I think definitely having that sort of open mind, you know, talking about the implications of their lifestyle, you know, trying all these different things to help that person fall pregnant. You know, even though, yes, we're older and, you know, we are more exposed to loads of things really over the course of our lifetime, which affects our fertility. So, you know, I want to thank you for your support for everybody, but also in your time, giving up time on a public holiday Monday. So thank you so much to answer questions and to really, I think people really appreciate having knowledge, you know, when they've been on this journey for a while, hearing from different people. You know, everybody has different opinions and different ways of looking at things, and it's incredibly helpful. I certainly really, the information that you said about the smoking probably needing even a very small amount, needing to double potentially their cycles, you know, and then obviously sadly increasing risk of childhood cancers in that potential baby as well. Hopefully anybody who is a smoker, partner's a smoker, will listen and hear that information, because I think we all know it's bad, but I don't know that everybody knows those sort of stats.
Yeah, no, I think thank you so much for having me. I have thoroughly enjoyed speaking with you. And, you know, as far as things like smoking are concerned, I just tell them, you know, if you stop smoking today, next year, this time you're going to have a great holiday in Europe, because that's the amount of money you're going to save.
I know, my gosh, it's so
smoke.
It's so expensive now. You know, when I was in high school, a packet was $5, and now somebody said it's like 40 or 50. Like, not only it's like really bad for you, it's like really expensive.
Exactly. But apart from that also, I think, you know, giving some common messages out and getting rid of those myths and misconceptions that go around in the community. And what better than social media can be a good platform, because that's what people are on all the time.
Absolutely.
If we can pass on some good messages on social media, and people like you are doing a wonderful job by trying to, you know, spread the message around. So thank you so much for having me. It's been a real pleasure to talk with you. And I hope that people who are listening to us gain something out of it. And of course, if they have questions, we can always have another session and keep going.
That sounds great. I'd love to chat again. Thank you so much. That's Dr. Sonal Karia from Jnea. Thank you. Have a lovely, lovely day. And thank you for your time on this holiday day as well.
Thank you.
Bye, Dr. Karia. Thank you.
Bye.
Bye.